Toxic erythema. Definition. Toxic erythema is a cutaneous response to a circulating toxin. In scarlet fever, erythrogenic toxin is elaborated by group A streptococci, Streptococcus pyogenes, usually infecting the pharynx. In staphylococcal scarlatiniform eruption, staphylococcal scalded skin syndrome, SSSS, and toxic shock syndrome, the responsible toxins are elaborated by a focus of Staphylococcus aureus infection or colonization. Cases of toxic shock-like syndrome have also been reported in association with severe infections with group A streptococci. In Kawasaki disease, aka mucocutaneous lymph node syndrome, a toxin is presumed but has not been identified. For all toxic erythemas, the skin becomes generally red, often feels like sandpaper, and undergoes post-inflammatory desquamation. Mucous membrane involvement is also common. A. Staphylococcal scalded skin syndrome, note nares as focus of infection. B. Toxin-mediated erythema from Staphylococcal aureus is accentuated in flexural fold. Incidence. Toxic erythemas are still uncommon, although they have been increasing in frequency in recent years. Children are affected most often, except for toxic shock syndrome, which usually occurs in adults. After the advent of antibiotics, scarlet fever became a less common and generally less serious disease, although this trend has been reversing in recent years. Neonates are at the highest risk for SSSS because of the decreased toxin clearance by the kidneys and a lack of antibody to the toxin. Erythema, scaling and crusting in an infant with staphylococcal scalded skin syndrome, SSSS. Widespread erythema with areas of erosion on the chest in staphylococcal scalded skin syndrome. History. Fever is common to all toxic erythemas. Patients with scarlet fever have a history of a sore throat preceding the rash by 1 to 2 days. In SSSS, patients may have a history of a local staphylococcal infection causing conjunctivitis, cutaneous abscess, or external otitis. Patients with toxic shock syndrome and Kawasaki disease look and feel the most seriously ill. Staphylococcal toxic shock syndrome was first described in menstruating women who used occlusive tampons that allowed staphylococcal organisms to proliferate in the occluded vaginal tract. This disorder is now more frequently found in postoperative patients. The focus of infection for staphylococcal toxic shock syndrome is usually the skin, most commonly an area of painful cellulitis on an extremity. The onset of toxic shock syndrome is abrupt. As the name suggests, hypotension is common, as are vomiting, diarrhea, severe myalgia, and encephalopathy with mental confusion. Patients with Kawasaki syndrome frequently experience abdominal pain, diarrhea, arthralgia, and other systemic symptoms. Physical examination. Toxic erythemas are characterized by a generalized, usually brightly erythematous eruption that frequently feels sandpapery and is accentuated in flexural folds. Post-inflammatory desquamation, particularly of the hands and feet, is common, especially in Kawasaki syndrome, but not pathognomonic. Toxic shock syndrome, generalized erythema that blanches. Kawasaki syndrome, desquamation follows erythema and edema of the hands, a typical finding. Laboratory and biopsy. Bacterial cultures from potential foci of infection are mandatory. In suspected cases of scarlet fever, a throat culture should be taken. Less often, streptococcal impetigo serves as the focus of infection. For staphylococcal toxic erythemas, a focus of bacterial colonization or infection should be sought and cultured. For women with suspected toxic shock syndrome, vaginal cultures should be obtained. In seriously ill patients, blood cultures should also be drawn because some patients with staphylococcal toxic shock syndrome are septic. The focus of infection in patients with streptococcal toxic shock syndrome most often is a severe necrotizing cellulitis, which should be cultured. These patients often also have positive blood cultures. Laboratory evaluation of other organ systems is appropriate in toxic shock syndrome and Kawasaki disease. These include tests of hematopoietic, hepatic, cardiac, and renal functions. In toxic shock syndrome, thrombocytopenia occurs early. In Kawasaki disease, thrombocytosis occurs late. The biopsy is nonspecific in toxic erythemas, except in SSSS, in which an intraepidermal separation is found. Therapy. Initial management of toxic erythemas often requires inpatient hospitalization, except for scarlet fever to provide intensive supportive care. Streptococcal disease is usually treated with penicillin, although penicillin-resistant strains of streptococci are beginning to be reported. Staphylococcal infections are treated with penicillinase-resistant antibiotics such as oral dicloxacillin or intravenous nafcillin. Intravenous gamma-globulin and aspirin are used to treat Kawasaki syndrome. Course and complications. Scarlet fever follows a relatively benign course, with complete recovery usually within 5 to 10 days. Penicillin has dramatically altered the course of scarlet fever in both duration and severity. Complications are uncommon with scarlet fever, although post-streptococcal glomerulonephritis may occur. Death has occurred in patients with toxic shock syndrome as a result of severe hypotension, sepsis, or multisystem organ failure. The death rate for streptococcal toxic shock syndrome is higher than that for staphylococcal toxic shock syndrome, 70% versus 30%, respectively. Fever is most prolonged in Kawasaki syndrome, usually lasting for more than 5 days. Death can result from Kawasaki syndrome, usually the result of coronary artery aneurysm and thrombosis, which is striking given the young age of these patients. Cardiology consultation and follow-up are critical. This complication occurs in up to 20% of patients and can be delayed by 1 year or more after the acute episode. For all these disorders, post-inflammatory desquamation usually occurs in 1 to 2 weeks. It is most striking on the hands and feet, where stratum corneum often sheds in large sheets. Pathogenesis. The toxins involved in toxic erythemas act as superantigens that directly activate T cells, thus causing the release of massive amounts of cytokines, especially tumor necrosis factor alpha, interleukin-1, and interleukin-6. These cytokines are thought to be responsible for the clinical manifestations. An erythrogenic toxin is produced by a lysogenic bacteriophage found in most strains of group A beta hemolytic streptococci. Although repeated streptococcal infections may occur, scarlet fever does not usually recur because of specific antitoxin antibodies that are formed from the first episode. SSSS is caused by a toxin produced by phage group 2S aureus. This toxin binds to and disrupts the desmosomal protein, desmoglein-1, which is heavily concentrated in the granular layer of the epidermis. This is why a skin biopsy in SSSS shows separation in the granular layer of the epidermis. In toxic shock syndrome, several staphylococcal toxins have been isolated, although the one most often implicated is an exoprotein-designated toxic shock syndrome toxin 1. Other toxins, example, S-pyogenes exotoxin, as well as the host responses to the toxins, also probably play a role in the pathogenesis of toxic shock syndrome.
Clinical case. A 3-year-old boy is brought to the emergency department with a 2-day history of fever, irritability, and increasing skin tenderness. His parents noticed redness around the mouth that rapidly spread to the face, trunk, and extremities. On examination, he has diffuse erythema, superficial flaccid bullae, and widespread tenderness. Gentle lateral pressure on apparently uninvolved skin causes superficial peeling, positive Nikolsky sign. The mucous membranes are not involved. He appears ill but has no hypotension or signs of shock. What is the most likely diagnosis? A. Toxic shock syndrome. B. Kawasaki disease. C. Drug eruption. D. Staphylococcal Scalded Skin Syndrome, SSSS. E. Toxic epidermal necrolysis, 10. Correct answer, D. Staphylococcal Scalded Skin Syndrome, SSSS. Key clue. A young child with acute fever, diffuse superficial tenderness, erythema, fragile bullae, and superficial desquamation, positive Nikolsky sign, and absence of mucosal involvement strongly favors SSSS. The condition results from exfoliative toxins produced by Staphylococcus aureus. Why the other choices are incorrect? A. Toxic shock syndrome, TSS, is caused by toxin-producing S. aureus or Streptococcus pyogenes and typically presents with high fever, hypotension, diffuse erythematous rash, and multi-organ involvement, renal, hepatic, muscular, neurologic, or GI. Desquamation may occur later, but superficial bully and skin peeling with marked tenderness in a young child without shock or organ dysfunction are much more characteristic of SSSS. B. Kawasaki disease usually occurs in children less than 5 years and causes fever greater than or equal to 5 days, bilateral non-exudative conjunctivitis, oral changes, strawberry tongue, cracked lips, cervical lymphadenopathy, polymorphous rash, and extremity changes. Flaccid bully, superficial epidermal peeling, and a positive Nikolsky sign are not typical. C. Drug eruptions can cause erythema, morbilliform rash, urticaria, or severe reactions such as SJS, 10. However, the case provides no history of recent medication exposure, and the combination of perioral erythema, superficial flaccid bully, epidermal tenderness, rapid superficial desquamation, and absent mucosal involvement strongly favors SSSS. E. Toxic epidermal necrolysis, 10 causes full-thickness epidermal necrosis, usually following a medication exposure, with widespread epidermal detachment and prominent mucosal, oral, ocular, genital, involvement. Patients are generally older, although children can be affected. In this case, the young age, absence of mucosal lesions, superficial rather than full-thickness epidermal separation, and classic SSSS presentation favor SSSS.